by Dr. Vagishwar for Medicine 5.
Good morning to all. Today I am presenting case take more than just muscle. A 49-year-old male from Jharkhand presented with a history of fever for 6 months and breathing difficulty for 6 months. He had a background. This fever was intermittent, low grade with evening rise of temperature and excessive sweating, relieved on medication with the dyspnea and exertion with effort tolerance reduced from associated with cough and expectation. There is history of loss of weight and appetite for past 3 years. No history of rashes, no history of chest pain palpitation, no history of bowel and bladder incontinence, no history of sensory symptoms or shooting type of pain. A background history: since 2019, he developed a progressive weakness of proximal muscles of bilateral lower and upper limb with the wasting of muscles. So no sensory involvement, no sensory symptoms. There is a significant history of weight loss, and for that he was evaluated the same in neurology department here in 2003 and got admitted for above complaint. Past history was he's not a known diabetic hypertensive. He doesn't have any other comorbidities, no history prior surgery. Personal history, he was a reformed ethanol consumer for 6 years back. There is no family history of any similar illness. Examination: when he presented in 2020 and admitted in you, he had a BP of 170, the pulse rate of 82. No pallor cyanosis, clubbing lymphadenopathy, no pedal edema. CVS RS examination was normal with parabdominal sub. CNS examination, iron function and the cranial examination of normal. Motor system, tone was hypotonia with the wasting of scapular, deltoid, biceps, gluteal, quadriceps and hamstring muscle on both sides, with a decreased power in bilateral shoulder and elbow and hip with a power of 2/5. And reflexes, he had an absent reflex in supinator, biceps and triceps with a 2+ reflex in knee and ankle. And the sensory system was normal. Sensory system examination normal with no signs of cerebellar dysfunction. Plantar or bilateral fracture. Gait at the time was waddling gait. Current admission: he presented with the pulse rate of 80. With the BP, initially it was not recordable needy, and after now it was 110/70. Saturation initially was 68. After it started to his saturation 94. With cold peripheries and pallor. He had a bilateral pitting pedal edema, and the JVP was elevated. And decreased blood zones in right infrascapular region with fine crepes in left infrascapular and interscapular region, and muffled outsole in all region. And the CNS examination, this time is IR function and cranial examination normal with the motor same wasting of scapular, deltoid, biceps, quadriceps and hamstring muscle with hypotonia, and reflexes are absent in biceps, supinator and tricep. Knee and ankle also the same as absent with the, and the power was like bilateral shoulder and hip, it was 1/5 with elbow and wrist of 4/5. And plantar was parietal flexor. Sensory examination was the same as normal. No cerebellar dysfunction. Gait, it was not assessed because bit bone. This is summary of the case. A 49-year-old male presented with progressive weakness of bilateral upper and lower limb proximal muscle with no cranial and sensory nerve involvement. Now presented with breathlessness with the pallor, pedal edema at elevated JVP and the basal capitation with muffled out sounds. Differentials considered was is basically on cardiac failure. Now differential consider inflammatory myopathy with immune mediated necrotizing myopathy, polymyositis, dermatomyositis, overlap syndrome, or any muscular dystrophy, or drug-induced or toxic myopathy, or metabolic myopathies like hypo or hyperthyroidism, dyselectroretinal. Investigations is basic investigation like HB platelet is normal with a total count of 8,100. Liver enzymes are little bit elevated. INR was 1.61 with his CPK. Initially, it was done on 2022. It was 1,782 at the time of admission. Later, it was reduced, and again it started to climbing up in 2003 or 2054, and last CPK was like 1,300 with the elevated drop T also with the urine 24-hour protein of 805. Its ABG was normal. This as alkalosis because of LASIX. And 2022 is ANA showed 2 plus cytoplasmic, and dsDNA and SSB was negative with myositis profile showing a SRB and RO52 was positive with the PA7 was positive, KU weak positive. And they were at the time left bicep muscle biopsy of them. It showed a myopathic feature with scanty endomysial inflammation, and EMG showed features of myopathy. Echo at the time, initially it was like LVH with grade 1 LV dysfunction, normal LV systolic function, and EF of 60. But current echo showing LV systolic function with global hyperkinesia and with pulmonary hypertension and RV dysfunction also present, and EF of 33 now. And a CT angiogram thorax was done here. It's showing diffuse ground glass opacity and honeycombing basal prominence noted in a visualized lung basis of both lungs, showing a future suggestion of ILD, and right moderate pleural effusion with cardiomegaly and moderate to severe pericardial effusion. A final diagnosis for the patient consider heart failure with reduced ejection fraction, pericardial effusion, dilated cardiomyopathy, and inflammatory immune-mediated necrotizing myopathy with a SRB positive, SRB4 positive with ILD. The patient admission initially from course of event was he presented with this complaint in 2022, and his CPK levels are elevated, and he was admitted in neurology, and it showed this future suggestive of immune-mediated necrotizing myopathy. At the time, his Vithil pulse was given and started on cyclopulse also, but he took only 8 doses and he lost follow-up. After that, now we presented with the complaint with showing cardiomegaly and infiltration lung, with the echo showing heart failure, with features of ILD also. Here we started on diuretics and anti-failure medication, and he also had a cardiogenic shock. For that, he was on inotropic support. We planned to start 4 doses of dexamethasone pulse was given, and the plan for secondary immunomodulation with rituximab. But unfortunately, before that, he expired. Few words about immune-mediated necrotizing myositis, which is a subgroup of idiopathic inflammatory myopathy. It's an autoimmune myopathy characterized by severe proximal muscle weakness with myofibril necrosis with minimal infiltration in the inflammatory infiltration in the muscle biopsy. The median age is 40 to 50. It's more common in female. And the subtypes of this based on autoantibodies usually was anti-SRB positive IMNM or anti-HMG-CR autoantibody IMNM or seronegative IMNM. Based on the lab testing, CPK was the most sensitive test for this with the myositis-specific autoantibodies. And testing usually will be done confirmation by EMG with muscle biopsy. And to rule out ILD, we have to do HRCT also. Usually, patient with the immune-mediated necrotizing myopathy has greater, more muscle enzyme elevation, more myopathy than other forms. And they also have a ILD, which has occurred almost in 10 to 20% of patients with anti-SRB myopathy. Other forms like anti-SRB are less frequent for ILD than this form. And muscle weakness prognosis are very worse than other forms of myopathy in this IMNM. And the percentage of IMNM patient who have persistent weakness despite having immunosuppressive weakness are so high. This is a diagnostic criteria for the IMNM with the clinical criteria showing an age of more than 18 with subacute or insidious onset with a symmetrical proximal muscle weakness and neck flexor weakness. And exclusion was the clinical feature of inclusion body myopathitis and ocular weakness and other isolated dysarthria and other causes like toxic or myopathy or family history of muscular dystrophy. With the elevated CPK of more than 1000, with the laboratory criteria showing positive EMG and muscle MRI showing increased signal within a muscle, and with positive myocyte specific autoantibodies, and muscle biopsy showing muscle fiber necrosis with sparse inflammatory infiltrate, and MSC deposition of small vessel with a rare tubulo-reticular inclusion in endothelial cells. This is a European Neuromuscular Center criteria for IMNM. It's showing this is anti-SRB myositis. Serological criteria was anti-SRB antibody. Usually, they mentioned muscle biopsy features are not required. Anti-SRB antibody positive with high serum creatine kinase to confirm anti-SRB myositis. Anti-HMGCR myositis with the positive anti-HMGCR antibody and proximal weakness. And antibody seronegative IMNM, we have to confirm it with the muscle biopsy. Treatment recommendation based on the induction, initially oral or pulse, oral steroids or IV steroids, pulse. After or within 1 month, we have to start secondly either oral or subcutaneous methotrexate or rituximab or IVIG. If not adequate response, we have to reconsider having rituximab regular. And maintenance, we have to taper oral steroid to minimum dose and to continue methotrexate at least 2 years of well-controlled disease and continue rituximab every 6 months. If IVIG was tolerated, also we have to taper as tolerated. This is one study regarding ILD in patient with immune-mediated necrotizing myopathy with anti-SRB positive myositis. The main objective of study to know frequency, clinical characteristics, or pattern of ILD in SRB IMNM patient. 130 patient with IMNM screen. Out of it, 60 patients have anti-SRB positive IMNM. About half of the patient with SRB IMNM have diagnosed with ILD. On HRCT, most of them showed a reticulation followed by GGO pattern and patchy shadows. 50 patient was evaluated with HRCT and 10 patient by X-ray. In that total, 27 patients were diagnosed with ILD based on lung images or pulmonary history pattern. 10 patients have ground glass opacity, 17 have reticulation, and 10 have patchy shadows. And 9 patients have consolidation. The more frequently myositis associated antibody, along with that, the frequency of ANA, SSA, and Rho52 also little higher in ILD group than without ILD. So ILD is more frequent in anti-SRB IMNM, and it is mentioned in this study as it was not severe, and the patient only present with disnoted dyspnea with exercise. The severity was only limited to, based on the study, they mentioned like severity only limited to mild or moderate in most patients. But the cardiac involvement will be severe in SRB positive patient. It's showing total 57. This is another study which showing cardiac involvement in IMNM. Like total 57 patient was diagnosed with immune-mediated necrotizing myopathy, included in the study for studying cardiac involvement. The cardiac involvement is most common extramuscular manifestation of anti-SRB antibody myopathy. The patient presented with either chest pain, palpitation, or congestive cardiac failure with the ECG changes and with the heart failure. Echo was found in then multi-center open. This is a multi-center open cohort study, including 230 patients. In that, 13 patients have a cardiac involvement with more than one feature, like 6 patients having a clinically evident myocarditis and 5 having conduction abnormalities. 3 is having dilated cardiomyopathy and 2 is having pericarditis and 2 is having premature coronary artery disease. So anti-SRB antibody myopathy is independently associated with cardiac involvement, regardless of the age, sex, and ethnicity, and lung involvement. Our patient, he has a dilated cardiomyopathy with myocarditis, and he has a severe heart failure with reduced ejection fraction. The reason for his death was due to cardiac involvement. The learning point in this case was anti-SRB myopathy patient. You have tend to have more severe weakness and more prevalent extramuscular features than other form of myopathies. And here, so we have to send intense and yearly immunosuppression therapy to avoid long-term disability. Most studies suggest the association between anti-SRB antibody and cardiac involvement. So regular screening of for heart disease in a patient with anti-SRB positive must be done to prevent mortality and morbidity.
Thank you, Vagishwar. I'll have to ask you to go back to your examination once. Yeah, I think we'll stick to the cardiovascular examination because this patient is known. So when we say muffled heart sounds, the usual differential is going to be what? When you use the word muffled, yeah, that's yeah, so usually you're expecting fluid, no fluid or something that comes in. Sometimes with obesity you can get. So classically, a muffled heart sound is not directly cardiac failure so much as we expect some kind of block between the cardia and your auscultation. Having said that, when you look at this, there's a JVP that's elevated or full. There is muffled heart sounds. The patient is in hypotension. Is there some triad that you could have thought of, which could indicate some based on the combination of findings that I just told you? Or yes, yeah. So Beck's triad, as everybody mentioned. So cardiac tamponade, of course, you said a fuller JVP, hypotension, muffled heart sounds. It'll go directly there. Though cardiac failure will be maybe softer heart sounds with a JVP elevated bilateral Krebs. He also had an interstitial lung disease, so it's a little difficult, though the Krebs quality may be a little different. So those are some things that when you went to your clinical syndrome, just show me the next slide, please. So here, I think that elevated JP basal Krebs, there is a failure component. But someone with proximal muscle weakness, you will think of a cardiac myopathy. But this may also indicate an effusion. So, but unfortunately, I think on imaging, the effusion part was very minimal. Okay, and cardiac tamponade will have its own kind of symptoms. So that's just one thing for mentioning of muffled cardiac heart sounds, and then the thought of cardiac tamponade. The other thing is, if you can just go to the CPK. So actually the tragedy of it is you can see the patient was responding to therapy. We've seen patients like this who don't respond to therapy or do badly. And unfortunately, if he had followed up, he might have done better because the CPK actually came down to almost half or even, more than half of the value. But I think he was feeling very well, so he didn't come back.
Yes, he advised cyclophosphamide, but he didn't come back after. Neuro also didn't follow up. So he came back again with this.
I think we all get lost in our work. It's difficult to follow patients at times. So unfortunately, otherwise he might have done much better. And, that's just a tragedy. So thank you for a good explanation about this process and a disease that we've all seen occasionally. So thanks, Vagishwar. We'll go on to the next, the last presentation for today from Puthalaraj from Medicine 4. Sorry, any other questions from the audience to Vagishwar? I didn't. Any question for Vagishwar from the group? No?